I'm Cello Tonelli. I'm an associate professor and kidney specialist at the University of Alberta. So we realized that as researchers, what we were really excited about was when we published a paper or did some work that had an immediate impact on health policy. It changed the way people did things, it helped the way patients were treated, and it made a difference in terms of outcomes. So our idea was, if we can meet with the people that are making the decisions that are going to affect the way the care is delivered and decide what their priorities were, we could sit in a room, we might have 10 or 20 ideas that they had, 10 or 20 ideas that we had. We wouldn't have common ground for all of them, but there'd probably be 2 or 3 ideas that were winners for both of us. One of the really unique things about our team is I think it can help to make better use of the way that healthcare dollars are spent. Currently in Canada, we're spending about $140 billion a year on providing healthcare. We're spending $11 or $12 billion right here in Alberta. Each year in Canada, we've spent about $1 billion a year on healthcare research, and we've made some really important discoveries. But research has shown that not all of those discoveries are being put to best use. We know what treatments work, we know who they work in, but we're not getting those treatments to the patient. One of the ways that we think we can really add value is to systematically study why people don't get the treatments that would benefit them, figure out why they're not getting it, figure out what the key barriers are, overcome their barriers, and partner with decision makers to improve their health. And we think by doing this, we're not only going to benefit the health of patients, but we're going to increase the efficiency of care, and we're going to make sure that the money that's been spent on healthcare research is well used.
I'm Brenda Hemminger. I'm an associate professor at the University of Calgary and a kidney specialist. The condition that we're studying, actually the chronic conditions that we're studying, are actually very diverse in nature themselves. And the conditions that we're interested in particular are what we call the vascular conditions, so diabetes, hypertension, chronic kidney disease, stroke, and myocardial infarction. So together, hypertension alone affects about 20% of the population, so we're 7 million Canadians. So it's a large proportion of the population. So it's a big problem, and in order to study a big problem and to improve care and outcomes, you need a diverse group of individuals. You need individuals with expertise in a variety of different areas. We've got a diverse team, actually. There are 23 team members from 14 key disciplines. So we cover cross disciplines from nursing to medicine to psychology, so a very diverse group of experts.
I'm Stan Waterman, a native Calgarian, and have been a kidney patient for almost 45 years. My problem started back in the early 60s with hypertension, and I seen doctors in Edmonton. They did some testing and found that I have what they call a horseshoe kidney, and that's where the kidneys are fused at the back. My kidney function is 13%. Anything less than 10% is dialysis. So I've been riding that very narrow line for a good number of years. I've been very fortunate that I've had good care. If I can inspire anyone to get into the process early, by all means, that's why I'm here.
I'm Bracken Men, an associate professor at the University of Calgary and kidney doctor here as well. Non-communicable chronic diseases are probably one of the largest and growing health problems that we deal with. Diabetes, high blood pressure, heart attack, stroke, these are what are killing most people. We have pretty good data that about 25% of people over the age of 65 have chronic kidney disease. But clearly, they're not all going to go on to develop kidney failure requiring dialysis. And in fact, then if we look in those 25% of people, only about 5 to 10% of people, depending on whether you have diabetes or not, actually have protein in their urine. And we know that's a very powerful predictor of the risk of going on to develop heart attacks and strokes and the risk of going on to develop kidney failure. So those are the people that we actually really need to be seeing, people who have some mild kidney problems but don't have protein in their urine. They probably can just continue to be managed by their family doctors, measuring their blood pressure and treating that. It's the people with the protein in their urine that we need to be seeing. So we think that if we just identified those high-risk type of people, we'd be seeing fewer people, and we'd be concentrating our resources on the most important segment of the population with kidney problems.